Good afternoon, everybody, and welcome to the Gintavines Health Foundation webinar today. We thank you so much for coming on time. Thank you for joining. Just to let everyone know, we are live streaming to YouTube. So we would like you to please be on mute unless you're called on to speak. Thank you so much. Now, before we bring on our speakers, we just have a welcome video from our founder, Dr. Andrew Agun, founder of Gintavines Health Foundation. I'll just share that with us now.
Welcome to this, which is our fourth meeting in the series of health education and information meeting. On behalf of the Board of Trustees, our ardent supporters and facilitators of Gintavines Health Foundation, I welcome you. And I hope you will stay all through the meeting. The topics are very topical, and we'll have very, very good speakers who are proven and distinguished in their field of study. Our projects and all we undertake are totally funded by money we raise from donations and fundraising. So if you are able to donate to our cause so that we can do more things, it will help. Our project manager, Mr. John Sangbedo, will be giving you details at the end of the meeting. I will now hand you back to our able coordinator and facilitator, Ms. Flora Coker. Thank you very much for joining us. And do look out for more meetings that we'll be holding in future. Thank you very much.
Thank you and welcome once
Welcome.
again. Oh, wants to play again. Alrighty, so yes, that was a welcome address from our founder, Dr. Andrew Agun. Once again, thank you. We'll go straight to our first speaker. We've got a great afternoon prepared for you, lots of information. Our first speaker is Mr. Emmanuel Ofosia. He's a consultant gynecologist and obstetrician. He's also the minimal access lead at the Endometriosis Center at the Croydon University Hospital here in the UK. He graduated from the University of Benin Medical School and he's a fellow of the West African College of Surgeons, the Royal College of Physicians, Surgeons and Obstetrics and Gynecology in the UK. He'll be the topic he's speaking on today is endometriosis and infertility. Over to you, Mr. Emmanuel.
Thank you very much. Is it possible to share my screen?
Yes, go ahead.
Thank you, everybody, for attending. And I'm hoping that you can all hear me, although I can't see the screen view, but if you can hear me, you can say that from your chat or type to say
yes,
you're
we
hearing
can hear
you. My name is Emmanuel Ofoasia, has been obviously introduced by our organizer. And I'm presenting a topic that actually is particularly dear to my heart, and that's endometriosis and management and fertility preservation. And obviously I'm going to be talking this for about 5 minutes. I hope I'll be able to do that. I will not be able to reach. And I presume that this is a mixed audience. So just in case you see something that will make you squirmish, you can look away. But I'll try as much as possible and do justice to these. Our first slide obviously shows my name and my fellow that works with me. And then obviously the next slide shows how patients sometimes can present. There are a lot of patients who actually have endometriosis. They are crippled in pain. And if you look at this particular slide over here, sorry, I'm not able to use the laser beam here. You can see the disease entities. That's supposed to be the uterus and the ovary and the bowel, everything's stuck together. You'll see what a normal uterus looks like. And that someone is just a pictorial representation of someone who obviously is in pain. And the next slide is just to tell you the aim of the presentation. And this obviously includes introduction and challenges when dealing with endometriosis and fertility, and management of hydrosalpinx or hematosalpinx. I'm not going to dwell much on that. And also deep infiltrating endometriosis, which you're going to see as I go along during this presentation. It's a mixed grill, and obviously it will be interesting to see what people think. Endometriosis is common in women in the reproductive age group and older. In fact, we're actually seeing them in women who are now menopausal, although they say when you get to the menopause, you are not supposed to have it because you don't have estrogen. But some now are presenting late. And you practically almost have over 100 million worldwide of women who have endometriosis. In the past, it used to say 70 million, but now people are now becoming aware and coming forward to be diagnosed. Why is it important? Like I said, affects about 1 in 4 to 6 women. Frequent cause of patients presenting to their doctors is even more common as migraine and back pain. It's a heavy and social economic burden to any nation at all and worldwide. And improper assessment and management can lead to unnecessary operations and inadequate management. How do they present? Symptoms include low abdominal pain, back pain, pain during sexual intercourse before and after. They can also present with bloating, and they may even present with urinary frequency. Treatment is often limited to relief of symptoms. Most of the time, doctors normally send them for ultrasound to exclude cysts, but that does not exclude they having endometriosis, because if they have peritoneal endometriosis, ultrasound or MRI is not going to pick that up. The review of trials found that a multidisciplinary approach helps alleviate symptoms in terms of managing between the multidisciplinary team. Cost of endometriosis, obviously, to the healthcare, systematic reviews have been done, and actually it's been shown that the study done in 2002, it cost about $22 billion in terms of resources to actually manage in these women, and I'm sure this has gone up. The costs are considerable, higher than those related to Crohn's disease or to migraine up to date. So it's not something we should take lightly, especially when you see people who are workers and they cannot attend work for several days or weeks because of pain or post-surgery, they are actually crippled in bed. What we actually suggest, and even the NICE guideline has now suggested, that to manage suspected endometriosis, consider referring all women with suspected endometriosis to a gynecologist, especially women with severe symptoms or subfertility, to confirm the diagnosis by laparoscopy and for medical or surgical management. The choice regarding referral will actually depend on the patient, will depend on the choice and the priority of what they want, whether it's the pain or fertility management, or indeed whether they've had previous treatment. It's also important to prescribe for them pain relief while actually they are waiting to be managed, because it's very important that these patients are actually groaning in pain and nothing's been done. I'm just trying to show you here a correlation between someone who has a cyst and you can see here, this is a chocolate cyst. If you can see my arrow here, and that's the cyst, which is the endometrioma. And also this is an MRI we've done. For patients who have large cysts greater than 4 centimeters, and there is suspicion of severe pain, we normally would do MRI in our center because of the dynamic imaging, and we can review this in a multidisciplinary setting. Scan can be done, but most of the time the scans are still images, but those who have dynamic images from their scan where they are stored and put on a CD, that will be fine. And it has to be a trained specialist who can do scan on patients with endometriosis. Another comparison is a patient who had an MRI where we could see that the ureter is involved, the arrows shown here. And during surgery, the fluorescent image during cystoscopy and stenting can show that actually this correlates with the MRI findings. The surgical teamwork has to be named clinicians. It's not just getting anybody around, oh, can you just come in and see if you can help release the bowel? It has to be those who actually are named, recognized by a particular center organization, like in the United Kingdom, it's called British Society of Gynecological Endoscopists, while in Europe, it's European Society of Gynecological Endoscopists, of which BSG belongs. And these particular named specialists are on record so that they know that these are the people who are actually managing them. There are a number of centers in the UK, and Croydon University Hospital is one of the named old centers that started these particular centers. And they have to be gynecologists, colorectal surgeon, urologist, anesthetist, radiologist who are involved in the multidisciplinary routine meeting, then the theater team in general. And these people are usually involved in discussion of the management and even in theater. Yes, then they talk about superficial peritoneal endometriosis, forget about it, don't do anything, give them the pill. Well, it's important how it affects fertility. I'm not going to just discuss fertility separately or discuss endometriosis, but I'm going to talk about them vis-a-vis each disease entity. In mild to moderate endometriosis, without disrupting anatomy, it's been shown that wherever possible, all visible disease in the peritoneum and nodule should be excised. This is proven to improve fertility as it reduces the peritoneal inflammatory effect and improve progesterone metabolism, meta-analysis in 2014. The infertile women with stage 1, stage 2 endometriosis, according to the revised American Fertility Society classification of the American Society for Reproductive Medicine, has also shown that it's important that we do that. So is the European Society of Human Reproduction and Endocrinology, has shown that it's important to excise that. I'll show you some graphs to actually corroborate this, how it's been done. I know that Akonde in the United Kingdom did a particular study where it's been shown that actually when you treat endometriosis, about 25% uplift of your chances of getting pregnant and brings you back to your normal peers for those who don't have endometriosis, so long as everything is normal. The same thing with unexplained infertility. And also this probability of ongoing pregnancy has been shown as well, where it's been shown that if you treat type 1 or type 2 or stage 1 or stage 2 endometriosis, or superficial endometriosis as it's called, or mild to moderate endometriosis, then the chances will be increased if that is treated, excised precisely. Now, I want to show you in this slide how the disease entity for deep infiltrating endometriosis, and the American classification would say stage 4, but this is actually deep infiltrating endometriosis as classified by BSGE, that's the British Society of Gynecological Endoscopy, and some European Society of Gynecological Endoscopies. On the right of the screen, you'll find that if you want to debulk, especially when the rectovaginal septum is involved, usually the group of patients will have pain during sexual intercourse. You can excise by debulking, and that's debulking. This white bit is taken out. Some of this dark bit is the disease entity that's still left behind. However, the second bit is complete excision, where actually the mucosa of the rectovaginal septum or the sigmoid has not been involved, and you can excise the disease completely, and then perhaps either suture the serosal layer, or you just leave it. Sometimes the integrity could be compromised, and there might be wounding the dehiscence. The other, obviously, is resection and the primary anastomosis, and that means you resect where the disease is and take part of that bowel out, and primary anastomosis is done. Sometimes there can also be breakdown, a leak, which has been quoted to be about 1 to 3% or even 6%. I don't know whether you're all hearing me or if I'm too fast, I can slow down, but I'll continue because there are a number of slides and video I'll need to show. This particular video shows this is not a big disease, but just for people who are squeamish to be able to see what the excision looks like. Sometimes you can have the bowel all stuck together. This is the pouch of Douglas, and that's the rectovaginal septum over there. We're moving the bowel out of the way, and this is where the resection actually shaving, this is called. It's not resection. So we are shaving more or less the disease from the rectovaginal septum over here. And the instrument I'm using here is called the plasma jet, more like a coagulator. It's akin to laser. The depth of penetration is about less than 2 millimeters. So they are you are less likely to cause injuries to the bowel. And we've actually sometimes demonstrated this on apple or egg, and that actually doesn't penetrate. This particular video shows you when you are doing this sort of operation, you need to identify where the ureter is. Otherwise, they are more likely to be injured. So what we want to do is to lateralize the ureter. Actually, I'm supervising my fellow here to do the operation because now they are going to be the surgeon of the future. And they are specialists now because they are graduated and qualified as postgraduate. So they want to specialize in minimal access surgery. So following that, what we do is to make sure that there's no hole in the bowel after creating hemostasis. I'll fast forward that. We actually put a fluid in the bowel. We do a rectal examination just to make sure there's no hole in the rectum or sigmoid, and then we'll put in fluid, which I've not shown in this slide, and put air bubble through the anal canal using either a 30 ml catheter, balloon catheter, or you use a sigmoidoscope and blow air. And if there's bubble of water coming under the water, you know that actually you made a hole in the bowel, that you need to go and fix it. But even if there's no bubble, that's not a guarantee that the wound cannot break down afterwards. All right, so we're just checking through. I'll go to the next slide. This is just to show you pelvic side wall involvement. You can see some small chocolate cysts and all that. These are just filmy adhesions and all that. This is not blood from the operation. This is just a backflow from the tube. I think the patient was menstruating at the time. So obviously taking a photograph when we go in to see what is in there before we start. And then another photograph will show you how we peel off these ovaries if they're stuck to the pelvic side wall as we go along. The next slide will show you a particular disease entity where we call kissing ovaries, and that's the uterus, and that's one of the ovaries, and that's the other ovary. You can see how close they are. You cannot see the pouch of Douglas like the other one we did where we're doing shaving of the rectovaginal septum. All these are bowel stuck together. Following surgery, you can see the uterosacral ligament. You can see the pouch of Douglas. So that has been freed. The ovary has been freed and all on both sides. So is the bowel. Then my fellow obviously is going through this. You can use several modalities of instruments. You can use scissors. In this particular one, you can use cold scissors or with diatomy if you don't have all the fancy equipment that I will talk about later. So he's trying to lateralize the ureter using the scissors here before going to the pouch of Douglas to free the disease. So you can see that particular ovary that was shown earlier, all the small endometriomas there, they're stuck to the pelvic side wall. So you need to actually free them bluntly, or in a way trying to dissect them, but not use energy. Otherwise, you could clobber the ureter. So this is what we try to avoid. Having a ureteric injury is not a nice thing to do, and also a nice thing to have. It's a nightmare situation for the patient, especially, and also for the surgeon. you have sleepless nights trying to sort out the patient. So following the separation and all that, then we'll now excise a patch of Douglas to see what's going on. So basically, this is just to show you that you can use other modalities of instruments. It doesn't necessarily have to be high-tech equipment, especially in countries where you don't have such equipment. But you need to be careful about the use of energy, especially close to the bowel and also close to the ureter. So now we're trying to go into pararectal space after dissecting the ureter and separating it. So identify the ureter and the blood vessels over there. Then we now actually go and then start dissecting the rectovaginal septum. So I'll skip this video just to give you an idea of what's going on, and then we'll go to the next slide. I'll show you some case studies where actually we can discuss and tickle your brain to make you ask questions. This case study one, is a 28-year-old who presented with pelvic pain and history of late miscarriage. She had an MRI scan which showed evidence of extranasal, which means the pelvic sidewall and the rectovaginal septum are involved. And she also had a longitudinal uterine septum, which I'll show you from the MRI image and the hysteroscopy, but that's not something I want to concentrate on. She also had a CT-KUB scan, which showed no urinary tract abnormalities. And our AMH level was 19 picomoles, which was normal, which was okay. The range is anything above 10. Anything above 30 is likely that the patient has PCOS. Anything below 10, the likelihood of actually stimulating those ovaries are very difficult. And the drop of AMH drops according to age, and also if you have endometriosis as well. This is the image of the septum, which you can see here, and shows the black line of what is happening in the cavity. And we did a laparoscopy on her, did some ureterolysis, and then make sure that everything else was okay, because she was going for fertility. And that's a video showing you the septum. And that's the septum between the uterus. For her to be able to conceive, we need to lyse this using a Vasa point, or you can use cold scissors through hysteroscope and severe it or cut it through, or cut it with a resectoscope. Having said that, you need to put in some agents to reduce the uterus having to come back together and causing further adhesions. So I'll forget about that and go to the next. Now, the next case is a 32-year-old who is nulliparous. That means she's never been pregnant. She's seeking fertility. She presented to a gynae clinic with severe cyclic pelvic pain and history of menstrual bleeding. There was no significant bowel symptoms. The ultrasound she had done suggested she had endometrioma, that is chocolate cyst on the ovary. The MRI reports advised for her to be discussed in a multidisciplinary meeting due to the deep infiltrating endometriosis, like I said before. So it's either it's superficial or it's deep. So an AMH had dropped to 6 and she's 33. So the chances of conception actually will be difficult because it's below 10. 10 will be borderline. AMH is anti-Müllerian hormone, which is a measure for ovarian reserve and the ability for the patient to have the ovaries stimulated and either conceive naturally or by IVF. So this patient had the MRI. So that's obviously the cyst showed by the arrow, and that's the uterus over there with the endometrium. And then the The next is that at laparoscopy, with all these multiloculated cysts. The question now is how we should manage this ovarian endometrioma. She has a borderline ovarian reserve and seeking fertility. The cyst is greater than 4 centimeters. So the risk of rupture is higher in her case. So what would be your thoughts? Maybe you can think about that. A lot have been talked about ovarian endometriosis, excision of endometriomas or ablation, the risk of damage to the ovarian reserve. People have talked about the chances of about 40% of women with endometriosis and 50% of infertile women will have endometriomas, as ovarian cysts, chocolate cysts. So the ovarian cystectomy, now the trend is that actually having to peel off the cyst, especially with women who are in the reproductive age group who are seeking for fertility, should not be the practice because of the loss of the ovarian reserve. And the AMH drops significantly. I'll show you a case study which demonstrates this. And people now talking about ablative approach, but using diatomy or bipolar diatomy, those also will destroy the ovarian reserve, especially the antral follicles. In our center, we use the plasma jet because the depth of penetration is less than 2 millimeters. So the chances of that damaging the ovarian reserve is lower. Or on the other hand, drain, wash, and come out. The ovary reconstitute itself, and then you leave them well alone. Some people are now trying ethanol, where you infuse this cyst with a balloon with ethanol, but that has not been published yet. It's just some randomized trial. You need to discuss all these surgical options with the patient, so at least they'll be able to decide and choose what they want. It has to be an informed knowledge. The next case, obviously, is a young girl, which will demonstrate what we've been talking about before, who presented in 2019 when she was 18 years old with acute pelvic pain. The ultrasound showed a hemorrhagic cyst, and the decision by the acute gynecology team where it was done was for an urgent laparoscopic cystectomy. And that's why you need gynecologists who are trained to know about endometriosis or what it is, fertility, to actually handle these women so that they are not managed badly. Image from 2000 emergency operation was that large cyst, which was on the left, on the vertical ovarian cystectomy, which obviously they did that, and that was the ovarian tissue left, and that was the cyst being extracted. And when we operated on her, sadly enough, in the endometriosis team, because she was complaining of pain, that was what was left of the ovary on the left. And this was a young girl. Therefore, it demonstrates actually you should have been doing cystectomy. You should either ablate with a low energy device, you drain and leave, in patients who have not completed their family size. And sadly enough, the AMH dropped following that previous surgery in somebody who was 18, but now in early 20s, to 2 picomole. So which means her fertility has been compromised. Summary of evidence from systematic reviews shows that the serum level of anti-malarial hormone should be assessed within 12 months of any surgical treatment of ovarian endometrioma. Clear discussion and documentation about the impact of treatment of endometrioma on ovarian reserve should be actually discussed. And the bottom bits just show you all the evidence. In my unit, what I tend to do for some years now is to advise these young ladies who are in reproductive age, 1, to have an AMH before surgery. They have AMH at the time of presentation when they are referred. CA125 is not part of mnemonic of any diagnostic pathology, but we'll just do that. And then they have MRI if we think that is severe. If it's not severe, we'll do a scan, then followed by laparoscopy or definitely treatment. What is the best way to achieve hemostasis after ovarian cystectomy? Some people use energy, but you have to be careful not to destroy the ovarian reserve or antral follicles. And now you need to use plasma jet laser because the minimal penetration of about 2 centimeters or less, sorry, 2 millimeters, I beg your pardon, or less. And it was proven that all types of energy devices, such as bipolar diatomy, ultrasonic energy, and hemostatic sealants, showed a negative impact on postoperative anti-malarian hormone, which is the AMH. So we need to be careful. Some surgeons will either suture, but that actually causes postoperative pain. So we need to be careful. Deep infiltrating endometriosis, interstitial nodopara, 3 years, infertility. Referred to our unit after having a diagnostic laparoscopy, showed obliterated, that is, everything is sealed, more like the pelvis practically obscure, you can't see anything. MRI scan showed rectovaginal septum involvement. The decision was very complex in terms of what we manage. Deep infiltrating endometriosis, does it improve fertility or not? There's a lot of debate, but I know one of my good friends in France has shown that his patients actually get pregnant. But sometimes on reflection, I actually think if you have a disease in some of the patients we see where the tubes are actually damaged, then it's unlikely that that fertility level that he is achieving is the case. So in deep infiltrating endometriosis, a lot of studies have shown that whether you manage or you don't manage will not actually improve the outcome of pregnancy. However, if you want to achieve egg collection, freeing the ovaries and freeing the pachyl duct glands to do that will be acceptable because it's not without risks. Bowel, having a bag with a stoma. We actually wrote a paper which showed that multidisciplinary team approach is the best way forward, and this has been published and it's been shown that it's one of the most cited papers in laparoscopic surgery for treatment of endometriosis. The management of hydrosalpinx, I'm not going to dwell on it because it's been a cause for debate whether you should excise or what not to excise, or whether you should clip. Now we are beginning to clip because we shown that when you take up the tube, energy that is transferred to the ovary will reduce the ovarian reserve, and been shown that this is the case when the tubes are taken out. So especially if there are a lot of adhesions, so it's better to clip the tube closer to where the uterus is, will help with improving fertility. All these are just what I've just been talking about. Comparing the laparoscopic salpingectomy and proximal tube obstruction, which is PTO, on ovarian reserve, the available data suggests salpingectomy halt ovarian reserve much more than clipping the tubes. Thank you for listening. I know I've taken some 4 new minutes, but I hope that has been of interest. Thank you very much.
Thank you very much for that. We have quite a few questions for you. If you just stop sharing, and then you'll be able to see all of us. Okay, so first question that we have for you is, what is endometriosis for the lay people on the who have joined us?
Shows that the people have been listening and very keen. That's very good. Yeah. It's an ectopic uterine endometrium, which is located outside the uterine cavity. This can be in the pelvis, this can be on the diaphragm, and when it's in the muscle of the womb, it's called adenomyosis. So I believe it's a continuum of the disease. There are some people who have cesarean section. They have ectopic endometrium in the muscle of the womb, or even the cesarean section scar, where we've excised a number of them. So, which lends to the fact that this is an ectopic uterine tissue, endometrial tissue, I'd like to say.
So is it a tissue growing outside of where it should not be growing? Is that what it is?
Growing, well, it's I won't say, well, grow is, well, it would be the layman's word. So the tissue of the lining of the womb is somewhere else other than the uterine cavity. So
Okay.
it would be even like when you menstruate, those two will bleed wherever they are and cause you pain.
Okay. All right. Great. Thank you for that. Now, next
just
question.
to add to that is that the current theory is that you're born with it. So it's familial or genetic.
Oh.
So that was why I was talking about growing. It may not be the exact word, but it's been laid down at birth when you have it.
So endometriosis is hereditary? Is that what we're saying?
Sorry?
Endometriosis is hereditary. Is that what we're saying?
Yep. Yeah. Okay. I've seen women where 4 mother, 3 daughters I'm managing. I've operated on them. And also a mother, but 2 daughters who were already married, but answering different names. They came on the day of surgery, and wow, I just could not believe that. No, yeah. So, although it's a telltale sign, but it's been shown that it's familial.
Okay. Wow, learned something today. So, is there a place for non-surgical management? Is it just, is it managed just by surgery, or is there anything else that can be done before getting to surgery, or is it when it's complicated you get to surgery? What are the treatment options?
Thank you for that question. Yes, there is the medical arm of management and also the surgical arm of management. For women in the reproductive age group who want to have pregnancy, you may find that that's why I didn't talk about it. Managing them medically will actually delay their fertility, because obviously most of the medications you're going to have, which will include oral combined contraceptive pill for those who are young as age 11 who are started menstruating, or 13 when they get to their 20s. You may have progesterone only pill. Then you may have GnRH analogs, which obviously acts at the center to actually shut down the ovary. That normally tends to actually reduce the symptoms. It puts you in a state of temporary menopause, but is reversible once you stop the treatment. And you can have some Depo-Provera, which is 3-monthly injection. The Zoladex is monthly injection. And then add painkillers, other painkillers. But once you take these, they can actually help relieve your symptoms.
So at what stage would there be a need for surgical intervention?
Well, as depending on the severity of the symptoms and their priority, what they want. If, for instance, they're trying for a baby and they've been trying for more than 18 months or about 2 years, then diagnostic laparoscopy will be the appropriate step first. If actually you don't find anything on scan and they still have pain, just to exclude superficial endometriosis.
Okay, thank you. So now, what is the incidence of endometriosis in Afro-Caribbean women?
I think the study that has been done is actually combined worldwide, which actually is about 1 in 4 to 6 in women in reproductive age group, which I said earlier.
1 in 4 to 6. So there's no research just looking at the subset of Afro-Caribbean women?
Well, people in the past just used to think that it was something that's particular to Caucasians, but actually we're seeing in the Afro-Caribbean women, because they always think that, when women have period pain, it's part of being a woman. No, it's not part of being a woman. When you have pain, go and get it investigated. And with that, a lot of people are coming forward now. They are becoming knowledge-wise and know-how-wise, searching for this on the social media or internet, and they are coming forward with or without referral from doctors to be seen. So now the incidence actually is increasing. You might find like it might be going to about 1 in 3.
Wow, okay. So early detection is key.
Early detection is good for young girls. And what we do now is advise them, for those who have endometriosis if they're young is to freeze their eggs, because as they go on, the ovarian reserve is going to deplete.
So, with what you've shared with us, it's, amazing expertise. But is it available, for example, in Nigeria? And if it's not, how can this skill be transferred?
Sorry, can you?
No, I said, so what you've shared with us, is incredible expertise in this area. Now, is it available in Nigeria? And if it's not, how can the skill be transferred?
I know I came to Nigeria once, that was some few years ago, but I don't want to go into story to see if I can help with sharing story. I know there are a couple of people in Lagos who actually have undertaken the training. I don't want to mention names, so I don't look like I'm advertising them. But I know his name is Christopher, and he's been trained. So whether they have the equipment is another question. But I'm sure he's been trained to be able to do minimal access surgery. And I also know that he's been co-opting in terms of education, bringing people from overseas to educate. So as it relates to other parts of the country, I cannot tell. I know that, yes, it's scarce. And a number of patients have been coming from Nigeria, parts of Africa to our unit, even from Mediterranean countries to come and have treatment. So, yeah.
All right. Okay. We need to build the capacity for that, don't we? And improve it. Okay. We have another question from Richard. If you could raise your hand and put your video on, and then you could ask your question, please. Then I can find you. Okay. Yeah. Richard Omosule, please unmute yourself and ask your question, please. I can see him there. All right, while he's trying to...
Can I stop sharing?
Yes, please. Okay, so while he's trying to unmute, Mr. Omosule, can you unmute, or the computer is saying no? Let me just go to the next question. Is IVF a viable option for patients with endometriosis?
IVF?
Yes.
Well, if the tubes are normal and the cavity normal, and all the other parameters, including sperm counts, then we shouldn't be talking about IVF, then they can conceive normally. However, if all these fail and maybe the tubes are damaged, then IVF will be an option. The question of even donor egg, donor sperm, I know sometimes it's not really welcome in our society, but you might find that that will be a way forward. Even adoption, we also advise patients. So to answer the question, yes, IVF is an alternative if everything is controlled.
Okay, thank you. I'll just go ahead and ask Richard's question. Is it safe to observe and repeat a pelvic scan showing a 3 centimeter unilateral...
Sorry, can you say that again? I can hardly hear you.
Can you hear me now?
Yeah.
Okay. Is it safe to observe and repeat a pelvic scan showing a 3 centimeter unilateral hemorrhagic cyst in 4 to 6 weeks if patient is hemodynamically stable? That's the question.
Hemorrhagic cyst is the key word. For hemorrhagic cyst, what we tend to do for patients who are not symptomatic is to actually rescan them in 6 weeks. If it's an hemorrhagic cyst, that cyst will resolve because it's cyclically based. However, if it doesn't resolve, it will form what we call a chocolate cyst, which can be detected by scan. And if they have symptoms, then you can operate on them. One thing you shouldn't do is actually start removing a corpus luteum cyst. One, you can basically lose that ovary because they bleed and bleed. Two, you are going to actually destroy the ovarian reserve. So it's better to actually manage them conservatively. One, because the cyst is less than 3 centimeters, the advice is that any cyst, endometriosis that are bigger than 4 centimeters, then you can advise operation. Otherwise, you can manage conservatively if they're not unwell. The other bit is if it's a simple cyst, 6 centimeters and above, you can operate. Anything less than that, manage conservatively, because all these are not without risk and raised to the ovaries as well. So to answer your question, manage conservatively if they don't have any symptoms for hemorrhagic cysts. Repeat the scan in 6 weeks. If it still persists, then and there's symptomatic laparoscopy.
Great. Richard, I hope that answers your question. Next question from Fumi. Fumi, could you unmute yourself and ask your question, please? And put your video on so I can see you. If you're here, I can see you on here. Why is everyone disappearing on me? All right, okay. So Fumi, if you're there, is she connecting to audio? No. All right. So her question was, oh, it's not allowing you to unmute. I've asked you to unmute. Go ahead and unmute. You should be able to now.
Perhaps you can unmute her.
Yeah, that's what I'm trying to do and see. Okay. All right, Fumi, try again. You should be able to unmute now. And then you could ask your question. No? All right. Let me just look for her question. She says, is it true that adenomyosis can go on its own?
Sorry?
Is it true that adenomyosis can go on its own? That's the question from Fumi.
That was a very clever and beautiful question. Yeah, it's been shown that it could be de novo. And also, sometimes when patients have DNC or evacuation of routine product of conception, or even when they have cesarean section, there have been implants in the uterine cavity. There have been theories that that can cause growth of adenomyosis, just like you see in patients who have cesarean section scar. So yes, it's possible that adenomyosis can grow on its own, that is de novo, because it's a continuum of endometriosis. On the other hand, it can be iatrogenic. That means it's been caused by something like cesarean section, DNC, ERPC. And one thing we should know, adenomyosis can also cause infertility, depending on the size, whether it's global or focal. And if the size is quite big, it will prevent implantation of pregnancy, causing miscarriage, whether you're having IVF or natural pregnancy. So that needs to be sorted out. Mostly it has to be medical treatment rather than surgical, which the Royal College advises and BSG. I know there are some surgeons in Europe who do Osala technique where they do a wedge resection of that particular area. You don't have a boundary and the healing is not that beautiful. And there have been reported some uterine rupture during pregnancy, even before pregnancy, following that procedure. I usually manage with Zoladex. Patients do well, and then they can go and try for pregnancy.
Great, thank you very much for that. Are there any more questions before we move on to the next speaker? Just raise your hand if you have any quick questions for our first speaker. No? Okay. Thank you very much.
Thank you.
Right, okay. So now we will go on to our next speaker. If you remember any questions, just type them in the chat. I will take them at the end of the program. If any questions do come to you, if you remember later. All right, so our next speaker is Dr. Ishaku Pam. He's a consultant physician and geriatrician. He's the clinical director of medicine and is based on the Isle of Man. Dr. Pam, over to you. And unmute yourself. Thank you.
Yes, thank you very much. It's my honor and pleasure to present today. I wish to extend my gratitude to Dr. Andy Agung and the Gentavinus Health Foundation for inviting me. And just to say thank you to the audience for finding time to attend, as well as to my esteemed co-speakers. So before I launch into my talk, I'll need to share my screen so that you can all see what I will be talking about. I hope everybody can see the screen, and I'm sure that you will let um, the either Flora or John know if you can't in the chat. So my topic is it malaria or typhoid? And this is a very topical issue. And I'm sure if I was to ask members of the audience to indicate either by raising their hands or doing so virtually, if not on their cameras, that a good number, particularly those who are residing in Nigeria, will indicate positively that they have been diagnosed with either one or both conditions in the last 12 months. So the purpose of this talk is actually to examine this issue more closely and to see how valid it is and what people's experiences are when they're diagnosed with malaria or typhoid. So conceptually, my approach to this topic is actually to frame a number of questions to tickle everybody's thought processes, just as I did. So why are we asking this question is number one. And why does getting it right actually matter? What are these diseases, malaria and typhoid? How are they diagnosed? How are they treated? And how do we get it right? So I'm mindful of the fact that this is a mixed audience, so I'll try and make this presentation as open to everybody as possible. So my slide here is shows you a young lad who clearly has water has been poured on him. So this is what we call tepid sponging. Many of you will relate to this when we've all been children, we've had high fevers, our mothers or parents or significant others have used cold water, if not cold water, then tepid water in an attempt to reduce our temperatures. Now, clearly the presenting symptom or situation is a high fever. And what is important to understand is that high fever is actually the body's response to a number of different insults, which could be infective or non-infective. And infection could be either viral, bacterial, fungal, or parasitic. In addition, there are other conditions which could present with fever. So I put neoplastic there, which refers to cancer. One of the common presentations of lymphomas, for example, is with fever. And there are other less common conditions which are autoimmune, which could also include inflammatory conditions of different tissues in the body. So for example, inflammatory conditions affecting blood vessels called vasculitis could present with a fever. And so we have to be mindful that fever is not a one-track presentation in the manner that it is handled in our country, particularly, and in other developing countries, where the general tendency is to exhibit the 3 A's, which are antimalarials, antibiotics, and analgesics, in the hope that you will capture one or more conditions by so doing. So to concentrate our minds a bit, I was able to pull up this study, which is an excellent systematic review by Prasad et al. And they looked at over 54,000 people who were studied in various researches around the world. And they focused particularly on West Africa, Southern and Middle Africa, Mid-Africa, North Africa, East Africa, Middle East, and Southeast Asia. They were looking at the etiology, which refers to the causes of febrile illnesses or fever in these areas of the world, which were described as low and middle income countries between the period of 1980 and 2013. So they were looking at publications in that regard. So they found that of the 54,000 causes, that malaria actually accounted for under a third, so 28.5%. Viral causes for 17.4%, bacterial and fungal bloodstream infections for about 10%, and then bacterial infections from animal sources about 4%. And then, very importantly, and I wish to draw your attention to that, is that almost half, i.e., 40% of the causes of febrile illness were unexplained. So it's important to have this figure in mind, and I would like to show you the importance of that later on. So in a subset of that population of 54,000, they looked at bloodstream infections and they stratified them into patients or individuals who are HIV positive and those who are HIV negative. And I just want to illustrate this because if you look at the row that refers to typhoid fever, which is the Salmonella enterica typhi, you will see that in both HIV and non-HIV, it amounted to about 10% of that subgroup. So therefore, even within this subgroup, typhoid fever is it affects the minority. In the HIV group, it's people with TB, that's Mycobacterium species, almost 40%. And then there were other bacterial infections, which you can see here, pneumonia, a non-typhoidal salmonella, and I'll talk about that later on, and E. coli and Staph aureus. So this illustrates that typhoid, for example, in a subset of people who have bacterial infection is actually even a minority. The final study I want to just make reference to is that by Isiguzo et al. In 2014, when they looked at 457 patients with fever in Nigeria who had all had some anti-malarial treatment. And in that series, 3.9%, that is 4%, were actually positive for malarial parasites. At the end of my talk is a list of references. So anybody who wants to ask me for those will be welcome. So let's move to the human angle. We've talked about the science. Now, this is a lady called Patience Adejo, who published an article in Nigeria Health Watch in March 2019, where she gives an idea of her experience. And some of you might relate to this. And she's quite eloquent, constant headaches every day, malaise, dizziness, and high temperature. I visited the hospital many times, and each time I was asked to do Widal tests, which always produced high titer values. The doctors repeatedly diagnosed me with typhoid fever until February 2019, when stool, urine, and blood cultures were done, which contradicted the most recent Widal test done 4 days before. So my ordeal at being repeatedly misdiagnosed with typhoid following 10 Widal tests over a 22-month period. So that's the human angle. And when I come to my next slide, which is why getting it right matters, is that 20% of patients with fever will die without the correct diagnosis and treatment. As you've seen from the last individual's experience, there is a huge degree of stress and anxiety. There's also a waste of time, energy, and resources, both for the individual and the health facilities involved. There's a loss of income, again, for the individual and for the health facilities. And on top of that is the risk of resistance to antimicrobial treatment. In subsequent slides, you will find that a good proportion of malaria parasites are now resistant to the usual drugs that we use. And not only that, the bacterial infections we treat are also resistant to a significant number of antibiotics. It's important for us all to understand the fact that pharmaceutical companies are not producing huge numbers of different antibiotics. So actually the antibiotics we have to rely on globally are quite few. And the more that uh, resistance develops to the existing antibiotics, the fewer that we have to deal with serious infections, and consequently the negative impact on mortality and morbidity. So it is really important to get it right. Now, moving on to the third question, which is what are these diseases? Malaria and typhoid. So let's start with malaria. It's actually from the Latin malus air, which is bad air, and it is a disease of antiquity, meaning that it has been identified for thousands of years, well before Christ. And there are references in Chinese writings and so on to the treatments that they were using at that time for a disease that fits the description of malaria. And in fact, they were using the bark of a tree called cinchona, which eventually quinine was distilled from. So the cause of malaria is a parasite called Plasmodium. There are 172 species of Plasmodium, only 5 of which infect humans. It's important to know which ones these are. They're called Plasmodium malariae, Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium knowlesi. The vector, i.e. the organism that actually carries these parasites and delivers them to the human body, the vector is the female Anopheles mosquito. So, what is the distribution of malaria worldwide? This slide shows you in red where the heaviest amount of malarial transmission occurs. And in the amber areas, you see where there is some transmission. And then in the white areas, malaria transmission is not known to occur. So what is striking is actually that malaria is endemic to tropical areas. It's endemic to those areas that are described as developing and low or medium income. It is also endemic in those areas where we know the health facilities are not as developed as the Western world. And in addition to that, the sanitary conditions are not as developed either. So this gives you a visual idea of the distribution of malaria around the world. And I would ask you to keep this picture in mind for when we come to the distribution of typhoid fever, because it's the same pattern essentially. So to understand the presentation and the diagnosis and management of malaria, it's important to also understand the life cycle of the malaria parasites. So as I've alluded to, the vector or the carrier of the malaria parasite is the female Anopheles mosquito, and the host is a human being. So the Plasmodium parasite just is a continuous circle around these two hosts. Essentially what happens is that the mosquito, which is infected with malaria sporozoites, bites the human host, and during that blood meal, it transmits these sporozoites into the human host. And once the sporozoites are within the human circulation, they go to the liver cells and My subsequent slide will show you the life cycle both within the mosquito and within the human being. So within these two hosts, there is development and maturation. There's also replication. And within the liver cells, the malaria parasites develop into what are called merozoites. And these merozoites, where two species are concerned, that is vivax and ovale, which are particularly common in Southeast Asia, they go into a dormant stage called hypnozoites in the liver. And in that dormant stage may erupt periodically to cause malaria, even when the initial infection has been treated. So this slide shows you what I've just been talking about, the life cycle of the malaria parasite. You can see the mosquito here. So over here, it's when it bites the human being and transmits the sporozoites, which then go into the liver and develop into these merozoites. And then the liver cells rupture, which is why you get evidence of liver damage and jaundice in severe malaria. When these merozoites are released, you have a group of them who then infect the human blood cell and reproduce again in the human blood cells. They cause rupture of those human blood cells, which is why you can get severe anemia with malaria. And then, they just keep, it's a vicious cycle. One set of red blood cells rupture, produce merozoites. Those ones go and invade other red blood cells. So more and more red blood cells are involved and rupture, and therefore you can understand why malaria can be a lethal infection. Now, some of these merozoites actually become the gametocytes, which are the forms of the malaria parasite that can reproduce. And so when the mosquito comes back, not only is it injecting sporozoites, but it is also sucking in gametocytes, which go into the stomach of the mosquito and develop further into sporozoites, and then the circle continues. When that mosquito bites another human host, it transmits the sporozoites. So that is the cycle of the malaria parasite in the human as well as in the mosquito. So how do we recognize it? I will talk about this when we get to the diagnosis and investigation. But this is just to follow on from the life cycle so that you can see when a blood sample is examined under a microscope, what the appearance might be. This is how the species of the Plasmodium is recognized. So starting with the Plasmodium falciparum in the first row, you can see what the ring form looks like, what the trophozoite form looks like, what the schizoid looks like, and what the gametocyte looks like. And it's the same with the other species. So a competent lab technologist should be able to look under a microscope and identify these forms of the malaria parasite and therefore make a confident diagnosis, which will assist with treatment. So it then means we move on to diagnosis. So diagnosis in any medical condition depends on three major things: the symptoms, the clinical signs, and the results from investigations. So in terms of symptoms of malaria, they are rather non-specific because, as I said earlier, fever is a situation that you come across with a wide range of causes. So patients can present with fever, with headache, with general malaise, with nausea, vomiting, diarrhea. And in the more severe and complicated forms, which include cerebral malaria, there can be confusion, disorientation, coma, and death. In addition to that, you may have sort of musculoskeletal symptoms like back pain and myalgia and chills. Now, before I leave this slide, a word about the fever. So the types of fever produced by the malaria parasites can have a pattern, and with the vivax and ovale species, the merozoites that are released from the red blood cells, that occurs every sort of 48 hours, every 2 days. So the fever in vivax and ovale types of malaria is described as tertian fever. That is, every third day you get a spike of fever. Whereas that from the Plasmodium falciparum, which is commonest in Nigeria, is described as a quartan fever because the release of merozoites is every 72 hours, which is every 3 days, and therefore the fever spike occurs every fourth day, hence the use of the term quartan. So how would you then investigate and diagnose with confidence a case of malaria? The gold standard is to use what is called thick and thin blood films. So the blood film is taken, it's processed in the lab, is stained with the Giemsa stain, and then if you recall the pictures of the various forms of malaria, the lab technologists would look under a microscope and be able to say first of all, to confirm whether it's malaria, and if it is indeed malaria, what species it is, as well as also to give a parasite density. So what percent within the slide is occupied by Plasmodium parasites, because the percentage density has a bearing on the trajectory of the infection, as well as how serious you would deal with it. There are other tests which I mention here only for completeness. They would only be used in tertiary centers or in research institutions. They're called rapid diagnostic tests, or the polymerase chain reaction. There are non-diagnostic tests which doctors would use to get a better idea of the status of the patient. So for example, a full blood count to look at, whether or not they have significant anemia, electrolytes and urea to look for renal impairment, liver function tests, because you would expect in severe cases that there is liver damage. And the CRP is a non-diagnostic marker of inflammation, because although you would be thinking about malaria, it's important not to lose sight of the fact that you might have a different infection, or you might even have co-infection. So these are the sort of routine blood tests you would do. You'd also want to culture the blood, the urine, and the stool, and consider things like the chest X-ray, HIV, and if you were looking more widely for other causes of fever, you would consider an ultrasound scan of the abdomen, or a CT scan of the thorax, abdomen, and pelvis. And you might consider, if you were thinking about inflammation of the vascular tree, you would do a vasculitic screen. So this slide here gives a distribution of the Plasmodium species around the world. And the green is Plasmodium falciparum. And it's clear that the major cause of malaria in Nigeria is the Plasmodium falciparum species. But the vivax species, you can see, occurs in parts of Africa and South America and Southeast Asia, whereas the Plasmodium ovale is more common, particularly in the areas around Iraq, Iran, Syria, Jordan, Israel, and Pakistan, as well as this bit in Myanmar and Laos and Southeast Asia. So that's where the Plasmodium is distributed. It's relevant to the treatment. So I'll move on to this slide, which shows you the distribution of chloroquine sensitive Plasmodium species, as well as the red, which shows you the chloroquine resistant species. So blue is where it's sensitive. And as I said, chloroquine was one of the first treatments, if not the very first treatment for malaria, highly effective where the parasite is sensitive to chloroquine, which is why it's really important to bear in mind the epidemiology of the disease, because it helps you decide what drugs to use. I should just add that you will see a blob of black there, and the black stands for multi-drug resistant Plasmodium species. And you will see that that's actually centered around Myanmar, which is Burma, and Thailand, and Laos and Cambodia over there. So that has been the fear globally, that the moment we get multi-drug resistant malaria, then we have a huge problem, which is why it really is important that a proper diagnosis is made before indiscriminate use of antimalarials or antibiotics. So in terms of treatment, this is a useful algorithm from the Center for Disease Control in America. I'm sorry that the slide is busy and it is quite small. I'd hope to be able to enlarge it. But what I want to draw your attention to is the diagnostic hierarchy. So from the history and the travel to the blood smear to whether it is positive and what the parasite density is, and then the assessment of disease severity, whether it's a complicated or uncomplicated malaria. If it's complicated, then you will want to use more aggressive treatment, which is intravenous, which would be Malaron or Coartem. But if it is uncomplicated and the patient can take medications orally, then you can use oral medications. But this is where your epidemiology and your tests are hugely important, because what treatment you give will depend on which species it is and whether that species is likely to be chloroquine sensitive or resistant. I would just want to focus on this bit here, which is where it's Plasmodium falciparum in chloroquine resistant areas. And that is where Nigeria sits. And so you would opt to go for Coartem, which is Artemether and lumefantrine, or you go for Atovaquone and Proguanil, which is Malaron, or you could use quinine and tetracycline, or quinine and doxycycline, or quinine and clindamycin. If you have no other options, then you might go for oral mefloquine. But be aware that mefloquine has the potential side effect of neuropsychiatric complications. So that's a rough run through for malaria. I'll do the same with typhoid, because we're talking about typhoid and malaria before we sort of round it up. Now, typhoid fever, it's an acute illness. It can be quite severe. It's caused by a bacterium called Salmonella enterica typhi. It's also caused by Salmonella paratyphi, but that causes a less severe illness. It's important to know that Salmonella is a ubiquitous organism, and it can cause a typhoidal illness, that is a typhoid type illness, or a non-typhoidal illness, which is called salmonellosis. And that's the sort that you get sometimes from chickens and so on. And that's a different type of illness. So we will focus on typhoid fever. The transmission of typhoid fever is via eating and drinking fecally contaminated food and drink. So typhoid fever is, the Salmonella typhi or paratyphi are excreted in feces, and where you have insanitary conditions and contamination of food and drink and the ingestion of contaminated food, then such people are at risk of developing typhoid fever. You will see that even when people recover, up to 5% of them become asymptomatic carriers. They don't know they have it, and they can continue to excrete it and contaminate food and drink. And such people, if they work in areas where they handle food and drink, then typhoid outbreaks may be the result. So um, the number of typhoid cases could be as high as 12 million per year worldwide, with 200,000 deaths. The comparator with malaria in 2019, there were 290 million cases of malaria with about 400,000 deaths. So moving on, I just digress a little bit to talk about carriers. So whenever typhoid is mentioned, this poor lady called Typhoid Mary, her name was Mary Malone. She was an Irish immigrant to New York, lived in Long Island, and she was a cook. She worked in the homes of the wealthy, and unfortunately for her, there was an outbreak in a home belonging to a wealthy man. He hired an investigator who painstakingly went through outbreaks in New York and was able to link an outbreak where Mary had worked previously, and therefore drew the connection that Mary was the source. So as a result of that, Mary was taken to an isolation center in 1907. She stayed there for 2 years until 1909, and then she was released, but was restricted to working only without the handling of food, so not to work as a cook. However, she went back to being a cook, and unsurprisingly, there were further outbreaks. And in that year, there were 13,000 deaths in the United States of America. Obviously, not all of them linked to her, but she had then become the public image of typhoid. And so she was once again apprehended and sent back to the isolation center. And this is from the internet. It is supposedly a picture of Mary. I'm not sure whether she's the one looking directly at the camera. I suspect she is, but there's also another lady looking away. But she was therefore incarcerated in an isolation center, which is this one, which is now closed. But she spent the rest of her life from the age of 39 or so to when she died. I think she was in her 80s. So that gives you an idea about the seriousness with which typhoid was taken previously, and the lengths that the authorities took to avoid typhoid outbreaks. So here's a map of the distribution of typhoid worldwide. If you remember the map about malaria, it's practically identical. The red areas are those where you have a high prevalence of typhoid. So you've got more than 100 per 100,000 people annually. Again, Africa, again, Southeast Asia, and the Middle East. Again, it's low and medium income countries, poor health facilities, insanitary conditions. Those are the ingredients for a high prevalence of typhoid. I will move over quickly. This is what typhoid bacterium does. It is swallowed, it goes into the intestinal tract, it goes to the lymph nodes, it goes to the blood. The incubation period is 5 to 14 days. There is a fever, which is said to be classical step ladder, highest as the day progresses, gets up to 39, 40 degrees centigrade. And then by the morning, it has subsided only to rise again. The organism goes into the lymph nodes and the blood, goes to what's called the reticuloendothelial system, which are the liver and spleen, bone marrow. And also the gallbladder is a repository for the bacterium, and the gallbladder can also become inflamed. It affects the lymph in the intestines, called the Peyer's patches, and can cause intestinal perforation. And it can go into the blood and called a septic-like picture. And it's also excreted in the feces, so other people can be infected. This is just a diagram of the symptoms. They don't all develop at the same time. The initial, within the sort of second week of infection, That's when you have, fever, chills, abdominal symptoms, diarrhea, but you can get constipation as well. And there is a skin a rash, which you can get. It's called rose spots. I'm not sure to what extent it would be seen on the black skin, but it's due to emboli, bacterial emboli in the dermis. In addition, you can get swelling of the internal organs, so the liver and the spleen, and the heart can be involved. Inflammation of the heart can cause a slowing of the heart rate, which is called a relative bradycardia. So complications wise, lots of serious complications ranging from intestinal perforation, gastrointestinal hemorrhage, hepatitis, which is inflammation of the liver, cholecystitis, which is inflammation of the gallbladder, myocarditis, inflammation of the heart, encephalopathy, which is inflammation of the brain. It can cause stupor and coma and death, can cause pneumonia, and uh, death can occur in between 12 and 30% of cases. And as I've mentioned previously, up to 5% will be chronic carriers. So the diagnosis of typhoid fever is blood culture, urine culture, stool culture. Bone marrow culture gives a higher yield, up to 80% sensitivity, but it's an invasive procedure and it's not done commonly. Now, the test that most people in Nigeria would or might be aware of is the Vidal test. And this is the test that is used inappropriately and used to then create the impression that patients are positive when they're not. The value of the Vidal test is simply to demonstrate antibodies to some of the antigens of the Salmonella typhi organism. And the test does not tell you whether, at least one single test does not tell you whether it's a current infection or it's a previous infection. And the only value that you can ascribe to it is if you do a series of tests and you demonstrate increasing levels of the antibody to the Salmonella antigen. So one test alone cannot give you a diagnosis and shouldn't be used to give a diagnosis, but that is the manner in which it is used in our environment in Nigeria, and hence the indiscriminate diagnosis of typhoid, which is questionable. So this is what the typhoid bug looks like under the microscope. It's a gram-negative bacterium. This is what's called a typhoid cell, which you might get in tissues. These are macrophages, that is the human's defense mechanism, which swallows up the organism as well as other bits and pieces. But when the typhoid cell is seen in the tissues, it is an indication that the individual has typhoid. So antimicrobial treatment, just to say, again, like malaria, there is now a high incidence of multi-drug resistance. So the fluoroquinolones, that is ciprofloxacin, ofloxacin, levofloxacin, which were previously very useful, there is now increasing development of multi-drug resistance, in addition to resistance to drugs like Septrin, chloramphenicol, ampicillin, cefuroxime, cefotaxime. So we're now down really to what the American Center for Disease Control would recommend, at least in their area, which is oral azithromycin for uncomplicated cases. And if it's complicated, then you might consider intravenous carbapenems. That's like meropenem in the treatment of typhoid fever. Now, obviously, the treatment is dependent on the area and the guidelines by the medical authorities in those areas, because they would use whatever culture sensitivities they have studied. So that's the treatment. My second to last slide is really how do we address this problem? Because what I would say is that actually the topic here rather than is it malaria or typhoid, it should be, is it malaria or typhoid or neither? Because as we've seen, 40% of patients with fever do not have either of those diagnoses. And so we should be looking much more carefully at the causes of fever in our environment, bearing in mind also that the risk of getting it wrong carries the potential for death for up to 20% of patients. So for the individual, it's important to seek medical attention early. It's important to attend a reputable medical facility and not just go to a lab, not just go and demand a vital test or go to a chemist and demand antibiotics or antimalarials. It's important for every individual to arm themselves with knowledge and to engage with their healthcare provider politely and knowledgeably, and to be aware of the meaning of some of these tests, and to take whatever medication is prescribed appropriately. So not to just simply go and choose one from a chemist or take it for a few days and stop, or not take enough. Our health authorities, our governments have a role. It is absolutely imperative that our regulatory framework for health facilities, for labs, are really tightened up, because there is simply a lot of unregulated activity, and there's no quality control as far as I can see. And therefore, you get all sorts of results from labs that you really cannot be sure whether they are valid or not. Our healthcare providers need to be educated, just like the populace, and we need to compile data and do research much more meaningfully. So, as I said, references at the end, quite a few of them I found useful, and I will stop at this point and say thank you very much for listening. In summary, we've looked at why it is necessary to understand between malaria and typhoid and causes of fever, uh, what these two diseases, malaria and typhoid, actually mean, how do we diagnose them, how do we treat them, and why it is absolutely essential that we get it right. So I'll stop here. Thank you very much.
Thank you very much, Dr. Pam. That was very interesting. The map, especially, looking exactly the same as each other, the malaria and the typhoid. Right. We have a question for you regarding the malaria vaccine. Would you like to say anything about that?
Well, the malaria vaccine is the holy grail. So there has been a lot about it, and it seems like the world is approaching it in a formidable way. Before COVID came in, it seemed like a lot of progress had been made. So so far, I am not personally aware that it's available for widespread use, but in recent months, there have been some very interesting developments, which no doubt many people, both in the healthcare industry and in the general populace, are watching with great interest.
Okay, so we wait and see. I'm just waiting for anyone else who has any more questions for Dr. Pam. Does malaria present differently in children? And same thing with typhoid to adults, or in
Um,
any of the different age group, children, adults, elderly.
the answer to that in general, no, they're non-specific. However, children, and bear in mind I'm not a pediatrician, but children have less reserve. So it doesn't take much to disturb the physiological balance of a child. So, within a day or two, a child could be at death's door. So, in terms of children, uh, the difference is in the severity and the rapidity with which infection can take hold.
Okay, great. Do we have any more questions for Dr. Pam? If so, just raise your hand. Okay, we just had a question from Tammy. Are the symptoms the same or typhoid is more severe?
Right. So I'm presuming that that's a question that is comparing
Malaria.
typhoid and malaria,
Yes.
and I think it's you'll be comparing two different things, apples and, uh, and 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 bananas, if you like. Each of them has to be considered separately. If you have a case of malaria, it can be uncomplicated or complicated. If you have a case of typhoid, it can be the same. Um, but either of them, once it's complicated, carry a high possibility of mortality. So you can't compare them head to head. For example, the simplest way of looking at it is to say if you had a choice between typhoid and malaria, which one would you prefer to catch? So I think it depends. It depends on how severe it is. So no, you can't compare them head to head.
Okay, great. If you've had typhoid, are you automatically a carrier? That's another question.
So
If you
no,
have
you're not.
typhoid, yeah.
No, you're not. 3 to 5% of individuals who have typhoid run the risk of becoming carriers. So, of those who survive, the majority will clear the virus or clear the bacterium and not be carriers.
Okay. We have another question from Richard. Is there any relationship of the malaria endemic regions with COVID-19 transmission?
So that's an interesting question. I think it has to do with the initial um, supposition that the sparing of Africa, parts of Africa and Southeast Asia um, by COVID, i.e., we were not seeing the kind of mortality in those areas as compared to the Western countries.
Mm,
So various hypotheses were postulated, including the endemicity of malaria and immunity having a role. But I think as the pandemic has evolved, it is the fact that it has had such high mortality in recent months in the Southeast Asian um, countries, I think indicates that the endemicity of malaria doesn't confer um, immunity in itself.
okay. I hope that answers your question, Richard. The next question is how can the practice of treating all patients for both be addressed?
Right,
I guess in Africa, yes.
a very good question. I think some of these, or rather many of these diseases that afflict developing countries and low and medium income countries, they point to a fundamental problem. They point to the need for root and branch reform of the health services. It is not by any coincidence that those maps I showed you are virtual mirror images or replicas. And I'm sure if you looked at other infectious diseases, it will not be different because these are diseases of deprivation. They are diseases of poor government and poor health institutions. So if you really want to address these diseases, just like the Western countries have, it is by addressing societal inequalities and societal issues. So that would be the solution in the sort of broad brush. But in terms of what else can be done locally, people need to be educated on the diseases. Healthcare professionals, particularly, need to be educated and refreshed around the common infectious diseases and how you diagnose them and treat them. And it just needs to be, the message needs to be hammered over and over and over again.
Yes, I agree. That message needs to be hammered over and over again.
Which is what
Yes.
we're doing here.
Yes, which is what we're doing here. Right, next question. That's just gone up. If there's, let's see. Is there no specific test? It's the question from Henry. Is there no specific test for typhoid? Especially because the Widal test is non-specific. I will not tell you whether it's a current infection or past infection.
Yes, so the tests that I mentioned, blood cultures, urine culture, stool culture, bone marrow, aspiration and culture, those are tests that will yield the organism. And, you know, that's what we need to rely on. And again, it goes back to our health facilities. When anybody has a fever, they need to be looked after in places where um, the practitioner, the healthcare practitioner, knows what to do, and the facilities are able to undertake those tests.
Great. Thank you very much for that. Are there any more questions for Dr. Palm before we let him? Well, he's not going. We still have the general Q&A at the end if there's any more questions. Okay. So we'll let you have a break for now, Dr. Palm.
Thank you very much. I
Thank you
appreciate
very
it.
much for that.
Okay, go on. Just one last
Oh,
question there.
yeah, there's one. Yes, I just saw it now. Go ahead.
It says, can someone who has had typhoid ever donate blood? The answer to that is yes, as far as I'm aware. But I'm happy to be contradicted because if you have cleared the virus, then there will be no particular need not to. And the blood, um, donated blood, usually is given lots of different treatments, which help to deal with current infections. But if anybody in the audience, and I do know that I have some distinguished colleagues in the house, if they have a contrary view, I would be happy to entertain it. I'm not a hematologist. Thank you.
Yes, if anyone has any wants to add to that or comment, you can just pop it in the chat, and then I'll read it out later. Thank you very much, Dr. Pam. And so now we go to our third speaker, who is here. I am very relieved that he's here. His name is Dr. Maurice Sanomi. He's a senior GP partner at a medical center in Romford here in the UK. He's also a GP tutor and educational lead. He's also a GP trainer and the clinical director of the Northeast London Clinical Commissioning Group. He has a special interest in ENT surgery. Dr. Sanomi, over to you.
Thank you very much, Flora. Can everyone hear me?
Yes.
Yeah, so if you notice my background here where I'm sitting, it's an unusual background. I'm actually sitting in a car because I've just finished a clinic to try and join the talk. So excuse, the sort of background. Thanks for the introduction. My talk today is on hypertension, and I know this has been going on. The meeting has been going on for a while, so I won't take too much time. I will just touch on some key areas. I think hypertension as a condition is well known to everyone, or almost everyone. Hypertension is a medical term for high blood pressure. I don't want to oversimplify things. I know there are medical and non-medical people on the call, but I'll try my best to keep the talk at a level where it's beneficial to everyone. Is it possible to share the slides at all, please?
Yes, John is just trying to share them.
Okay. So before we do anything else, it'd be good to have a definition of hypertension. So what is hypertension? Hypertension is defined as persistently raised arterial blood pressure. And when we say arterial blood pressure, we talk about the pressure within the arteries the body has basically two types of blood vessels, the arteries which carry blood away from the heart, and the veins which return the blood back to the heart via the lungs where oxygen is added. So what do we mean by persistently raised? Persistently raised means blood pressure that's over a certain level or certain figure. Now, for those who may have had their blood pressure checked, or those who practice and do blood pressures, you will know there are two readings. The top one is referred to as the systolic reading, and the bottom one is referred to as the diastolic reading. Now, if blood pressure at the top is persistently above 140, or the one at the bottom is persistently above 90, then you can say that person has high blood pressure. So the two figures to be aware of is 140 at the top and 90 at the bottom. However, if you're 80 or over, the top figure may then be 150 and above before we say you have high blood pressure, but the lower figure remains 90. So what do these two figures mean? The top one, the systolic, that systolic figure represents the force at which the heart pumps blood, around your body. And the lower figure, the diastolic, represents the resistance of your blood vessels to the blood that is being pumped around your body. So those are the two figures to bear in mind. Now, before we go any further, let's have some classification of blood pressure. So blood pressure can be classified as primary or essential hypertension. So primary just means there is no known or identifiable cause for the rise in blood pressure, or the persistent rise in blood pressure. And 90% of cases fall into this primary or essential hypertension. The other 10% are classified under secondary hypertension. That means they're secondary to a known cause. So 10% of cases, there is an identifiable cause, and they are referred to as secondary hypertension. If we talk about hypertension, it's good to talk about, stages of severity. And we talk about 3 stages. So you have the stage 1 hypertension, stage 2 hypertension, and stage 3 or severe hypertension. These are classifications that NICE.
Sorry, Dr. Sanomi. Can you see the slides?
Not yet, but don't worry. I will keep talking until I don't know if everybody else is seeing.
Okay, I'm going to try and reshare from my end again. So, John, if you could just stop sharing and I'll try.
It's not showing.
Yeah. So, John, if you could stop sharing and I'll try it from here. Apologies, everyone. Let me just try and do it from my end.
Okay. Do you want me to continue? Or?
No. Just give me one second. All right. Can we see the slides now?
Yeah, I can see them now. Yeah.
So is this where you are? This is where you've got to.
That's where I am. Yeah. Yeah.
Oh, perfect. Okay, let me just make it on slideshow. Okay.
Yeah. So as I was saying, we classify the severity into 3 stages. So you have stage 1 hypertension, stage 2 hypertension, and stage 3 or severe hypertension. This is taken from the National Institute of Clinical Excellence, NICE. NICE is a body that gives a lot of guidance on what, medical or healthcare professionals should do or how they should manage conditions. So the difference between them, these 3 stages, is the height of the blood pressure. I'm not going to bore, you all with trying to go through all the various stages in detail. But just to point out that the stage 3, which is severe hypertension, is something we need to take seriously. And that is defined as clinic systolic blood pressure of 180 millimeters of mercury or higher. Or if you have a clinic diastolic blood pressure of 120 millimeters of mercury or higher. So the systolic, like I said before, is the top value, and the diastolic is the bottom value. So those 2 figures are the figures we need to bear in mind, 180 and 120 at the bottom. Blood pressure is measured in millimeters of mercury. So this is why those figures are represented in millimeters of mercury. So if you have severe hypertension, as we will come to later, you need to take some immediate action or take some action to make sure the patient is managed appropriately. So we've talked about stages. Now let's look at, the sort of risk factors for high blood pressure. These are just some of the risk factors. We cannot touch on every single one, but we'll just talk about some of the, important ones. So at the top there, you see age. Age is a risk factor because with increasing age, your blood vessels, harden, and then they become more resistant, and that's why blood pressure becomes more common as we get older. The other factor is family history, and we hear about blood pressure running in families. You say essential hypertension on this is blood pressure. Like I said before, where there are no non-identifiable cause. But familial or family history plays a role as well. So blood pressure, if you have someone in the family with high blood pressure, then that raises your risk of developing blood pressure as well. The next one is diet, so high salt intake for people who are sensitive to salt. We also have other, possible contributing factors or risk factors, such as kidney problems. We've talked about diet already. There's also endocrine, conditions. Endocrine, these are glands that produce certain types of chemicals or hormones, which can have an impact on blood pressure. Excess alcohol, obesity, all these are possible, factors that can raise your risk of developing blood pressure. You also notice there we talk about sleep. So poor sleep or sleep deprivation. And there's also obstructive sleep apnea, where people sleep, they think they've slept through the night, but they've woken themselves up several times through the night. They may not be aware that that's actually happened. They wake up in the morning, they feel, very tired, unrefreshed, a situation we call obstructive sleep apnea. And there are certain medications as well that raise this risk that we're talking about. And I'll just point out the one called NSAID, which is non-steroidal anti-inflammatory, drugs. These are drugs that we take for pain. Something like ibuprofen belongs to that group. Nurofen, ibuprofen, which a lot of us may have heard of, belongs to that group. So they can raise your risk of blood pressure. And lastly, I'll just talk about, race. So Afro-Caribbean or Black race raises that risk as well. So that's relevant to most of us on this platform, because I know majority of us belong to, that race. So these are some of the risk factors. Like I said, we cannot touch on each and every one, but just to bear those in mind. Next slide, please. So now we've talked about what hypertension is. We've talked about some of the risk factors, the levels that we should bear in mind. If you have high blood pressure, what are the symptoms that you will experience? And I'll say to you, majority of the cases, or majority of the time, there are no symptoms. So you find that someone may have very high blood pressure, they feel well, they feel nothing until that blood pressure, either gives them a stroke, heart attack, or some other complication. So majority of the time, there are no identifiable symptoms. However, there are some symptoms we will say are non-specific in the sense that they are not specific to high blood pressure. But when you have high blood pressure, you may experience some of these symptoms, and they include symptoms such as, headaches. Some people may develop chest pain. We talk about nosebleed, visual disturbance, dizziness, or even shortness of breath. These are possible non-specific symptoms that may point out or may, relate to a rise in blood pressure. But majority of the time, blood pressure is silent. There are no symptoms, and it could be classed as a silent, problem, epidemic, or killer in whatever sort of way you want to class it. But be aware that you can have high blood pressure without experiencing any symptoms. Next slide, please. So I just wanted to touch about this phenomenon called white coat hypertension. So white coat hypertension is hypertension or blood pressure that is unusually raised when it's measured in a clinic situation or in a health, circumstance or health setting. But when that same blood pressure is measured in a situation where that patient is relaxed, maybe at home or in a non-threatening environment, that blood pressure is normal. So it's referred to as white coat hypertension because if you think back, a lot of doctors in those days used to wander around with white coat, and it still does happen. So maybe seeing that white coat raises the anxiety or stress in the individual whose blood pressure is being measured. So this is why it's called white coat hypertension. So you measure it in a clinic setting, it's high, unusually high. Patient goes back into their, relaxed environment where it's non-threatening and that blood pressure is normal. Next one is malignant hypertension. So malignant hypertension just indicates accelerated hypertension where you have very high blood pressure, but in addition, you may have signs of bleeding behind the eye, which is retinal hemorrhage, or swelling around the nerve at the back of the eye, something called papilledema. So if you do get this sort of malignant or accelerated hypertension, where usually the blood pressure levels are very high, up to about 180, 120, and even as high as up to 220 over 120, these are patients that should be referred to see a specialist immediately, same day, because they need that blood pressure to be managed, to be brought down into a level where it doesn't pose any sort of immediate risk or threats to the individual. So that is called malignant hypertension. How do we diagnose hypertension? I've talked about the levels to look for. So if you check your blood pressure and it falls within those levels repeatedly, it means there is the possibility that you have high blood pressure, and you may want to confirm that diagnosis using other, methods. One of the ways we diagnose blood pressure in the medical setting or in the healthcare setting is to do something called an ambulatory blood pressure monitoring, where the patient gets a machine attached to them, they take it home, it automatically measures their blood pressure at intervals over the course of about 24 hours or so, and that machine is then taken back and the information is downloaded. And the information is then analyzed to see what the average blood pressure is for that individual through the course of that measurement. Another way of diagnosing blood pressure is to do home blood pressure monitoring. So if you see someone you suspect may have high blood pressure, if they have access to a blood pressure machine, you may then ask them to do serial blood pressure measurements at home and to log them, and then bring that reading or bring those readings to you to have a look at to see whether there is the possibility of them having high blood pressure from those readings. But ambulatory blood pressure monitoring is what we use in the medical setting to confirm blood pressure or high blood pressure. And the averages to look for with the ambulatory blood pressure monitoring is 135 over 85 and above. So if you have those sort of levels, then that confirms the diagnosis. So also talking about diagnosis, like I said, clinic blood pressure, if it's above a certain level, you need to, confirm that. Next slide, please. So I've already talked about this. So the average is to look for, like 135 over 85. If you have that or higher from the ambulatory blood pressure monitoring, then yes, the diagnosis can be made then. Next slide, please. So now that you've measured the blood pressure, you've diagnosed, or you have a suspicion of high blood pressure, what else do you want to do? It's good to do a physical examination to look for signs of, high blood pressure damage or end organ damage. Or we talked earlier on about people with severe hypertension who may end up with bleeding behind the eye, for instance. So physical examination will include, weight, checking for blood BMI, which is the ratio height to weight ratio, and over 25 is high, anything below 25. So 18.5 to 25 is the ideal. So you check their BMI. You will also want to make sure you check their pulse. The significance of checking the pulse is if it is irregular, then using the automatic blood pressure machines may not be accurate. You may want to check the blood pressure manually if you have an irregular pulse. It's also good to listen to the heart, so listen for murmurs. You also want to check if the heart is enlarged. Like I said before, looking behind the eye, which is fundoscopy, is also something that it is good to do at the physical examination when someone's diagnosed with high blood pressure. Next slide, please. So there are some other relevant tests you may want to do, and these include, blood tests to check for kidney function and look for other possible secondary causes of the high blood pressure. You may also want to dip the urine to check for protein or blood, which may indicate kidney damage. You also would consider doing an ECG, which is a tracing of the heart, electrocardiogram, which then looks for evidence of what we call left ventricular hypertrophy. And the left ventricle is the main chamber of the heart, which pushes the blood out. So if it's pushing against resistance or against high pressure, over time it may become enlarged. So an ECG may give you an indication whether that's already happening. And lastly, you may want to do something called an echo, which is an echocardiogram. Is a scan of the heart to look at the structure of the heart. It will also tell you if the heart is enlarged, if the chambers are enlarged, or if there are problems with the valves. So these are things you may want to do as part of, the examination or relevant test for someone who's been diagnosed with high blood pressure. The echocardiogram may also measure the output of the heart and may indicate whether or not there's evidence of heart failure. Next slide, please. So what are the consequences or complications of high blood pressure? I've just listed a few here, but at the top there you see stroke. Stroke is bleeding into the brain or clot in a blood vessel within the brain leading to death of that part of the brain and therefore loss of the functions controlled by that part of the brain. So blood pressure is one of the known causes of stroke. So if you have high blood pressure, it's important that you control it because of that reason. There are others there like coronary heart disease, myocardial infarction, which is heart attack, heart failure. So there are quite a number of things that can happen. I've got a few other slides, but I might just skip through some of these. I can see on the slideshow, it's gone to the last slide. Hello, Flora, is everything okay?
Yes, I don't know why it's jumping.
All right, okay.
So which
All right,
slide
so
would you like me to go back to?
I was just talking about the complications or consequences. And some of the other things are damage to your kidney. You may even end up with damage to the blood vessels in the brain, leading to memory loss, which is dementia. There are other complications like if you have a bleed behind the eye, you may have visual loss. The heart may fail. All these are possible consequences of high blood pressure. Next slide, please. So we're talking about where or how to check your blood pressure. So there are so many places where you can have your blood pressure done. Nowadays, there are automatic machines are readily available, so people can buy and measure their own blood pressure at home. You can have this checked at the GP surgery or health centers. You can go to local pharmacies. Some workplaces have machines where staff can check their blood pressure. And lastly, if you're in the UK, as part of the NHS health check, if you're between the ages of 40 and 74, blood pressure is part of the NHS health check. So you'll be offered that as well. So you can use an automatic or manual blood pressure machine. Like I said before, if your pulse is irregular, you may want to measure that manually using a stethoscope and a BP machine. Next slide, please. So these are the, nearly at the end. We talk about prevention. How do you prevent blood pressure or prevent high blood pressure? We've talked about the risk factors. Age, you cannot do anything about. We will all get old one day, hopefully, without too many, chronic problems. But age is something you can do nothing about. Race, you cannot do anything about, but there are things, and family history as well, you can do anything about. So those three are non-modifiable, risk factors, but there are other risk factors that you can modify. And these are things like watching your diet, increasing exercise, cutting down alcohol to less than 14 units per week, reducing, smoking, try, mindfulness to reduce stress. So there are a lot of all those things you can do to modify some of the modifiable risk factors. We've talked about diet, improving your diet by eating, incorporating fruits and vegetables, reducing coffee, for instance. All these are things that you can do to reduce the risk or prevent high blood pressure from developing. So if you know of modifiable risk factors, like we've talked about, then take steps to modify them, increase activity, reduce weight, reduce your body mass index. So those are some of the things we can do to prevent high blood pressure. Now, we've talked about prevention. We need to talk about treatment. And basically part of treating any condition is not just taking tablets, but to do the things that you can do to manage the condition better. And that includes lifestyle changes. So we've talked about reducing alcohol, cutting down smoking or stopping smoking, preferably, watching your diet, increasing exercise. Medications are usually recommended if your blood pressure, is not controlled by some of these measures, or if it's very high, or if there's already evidence of end organ damage, then it may be necessary to introduce medication at the outset. There's also, in terms of medication, there are several medications, but there is the British Hypertension Society, which also gives guidelines, and they've said if you're 55 or under, then start with something called an ACE or ARB. This is a group of drugs that work through the kidneys. But if you're over the age of 55 or you're Afro-Caribbean, then take something called a calcium channel blocker. The reason we talk about a different drug for Afro-Caribbeans of any age is because these other drugs do not work so well in the black race. So a calcium channel blocker is advised as a first line. So treatment is usually lifelong. And remember, once you're on treatment or once you've been diagnosed with high blood pressure, you need to check your blood pressure at regular intervals to make sure that your blood pressure is kept under control and whatever medication you're taking is controlling your blood pressure. Next slide, please. Okay, so I think that's the last slide. Just to say some of the information is from the National Institute of Clinical Excellence. And I'm conscious of time, so I'd like to stop here. I'm sure there'll be questions. Thank you very much. Thank you for listening. Thank you for your time.
Thank you very much, Dr. Sanomi. Yes, there are some questions. First one is, how accurate are smart the watches to measure blood pressure? The smart devices and the wrist blood pressure measuring devices. So the smart watches and
Yeah, they will give you a good indication of your blood pressure. However, with any electronic device, there's always a margin of error. I would prefer the one done at the arm, just above the elbow. But the wrist ones, now technology has moved on, they're a bit more accurate than before, but there's always a margin of error. And if you have that, it's better than nothing. And I will encourage you to use that to keep an eye on your blood pressure. But it also depends on different brands as well, or different manufacturers. And provided it meets the kite mark, they say, to make sure that the machine itself meets certain standards before it's released onto the the market for people to to buy, then you can rely on it to, a reasonable extent. But if you use that and it shows that your blood pressure is high, I will encourage you to still have that checked by a healthcare professional or by a different method, just to make sure that it's not giving you false readings. But they are a good, they give you a reasonable indication of whether you have problems with your blood pressure or not. Even with the others, we talk about serial measurements. That's why we talk about, ambulatory blood pressure measurements. So if I measure a blood pressure in a clinic, I will still need to try and confirm that by doing several. So that is something I would say with these sort of risk measurements, they give you a good indication, but do still go ahead and use other means to confirm if there's any, if it's giving you high readings, for instance.
Okay, great. So you were talking about the white coat hypertension earlier on, and there's a
Yeah.
comment from a Dr. Francis. She said, would you consider renaming the white coat hypertension to spare the color white and the coat from being seen as if they are the sole cause? Maybe environmentally induced hypertension could be a better name.
That's a very good point. I think over time, we're more conscious of how we name things. Yes, it could be, I think people have said that before as well, but it's what everyone will be able to immediately recognize. So if
Mm,
we say white coat hypertension, a lot of us, will be able to dial into it, so to say, and know what we're talking about. But
mhm.
it may be that we talk about clinic induced or healthcare setting induced blood pressure or whatever. It's not something that I have any control over, but it's just something that's been out there, over the years. Even when I was a medical student, these are things that we were being, told. So it's something that's been there. That nomenclature or that sort of tag has been there for, for as long as I can remember. Maybe we should make concerted efforts to say, let's rename it and see what's the best way to rename it.
Yeah, so yeah, point for discussion maybe somewhere.
Yeah, something like that. Yeah.
Yeah, whoever makes those decisions on what to call it.
Yeah.
Okay, so another question, a question from Helen. What um what in the Afro-Caribbean race makes them prone to hypertension? Is it our diet or something in our genes?
It's a very good question, and I can't say definitely this is the reason, but there may be several factors. You've talked about diet, for instance. Um, there may be some element of genetics there. Um, when you talk about race and diseases, you always tie it down to either behaviors, environmental factors, or genetics. I'll give you an example. For instance, a lot of the times people, I know when in our society, you see someone who is obese, you say, oh, they're living well, they are fresh and things like that. Unlike in this sort of environment when people are so conscious about body mass index, not to say there are no obese people in the Western world, but they're more conscious of it. So it could be because we don't take those steps early enough. We don't watch our diets early enough. We don't check early enough. And like I said, there may be other factors. There may be a bit of genetics in there as well. So it's difficult to say one specific factor contributes. It could also be, like I said earlier, there are secondary causes of blood pressure. And I did mention, kidney problems. So it could be a lot of other things linked to that. Um, so, yeah, so, yeah, sorry, somebody's talking to me. All right, okay. Yeah. Oh, they want to, lock the car park. Yeah. So in any case, like I said, it could be a number of different factors, and I think genetics will be part of that. Environmental factors will be part of that, and diet will be part of that as well. So I think it's a combination of factors.
Okay, so we will let you move your car, and then
Yeah.
I'll come back to you.
Okay then.
While you're doing that, I would just we will come back to the questions for Dr. Sanomi. We just need him to move his car safely. If I'll go over to John now, John will just have a few words to share with us, and then we'll come back to the questions for Dr. Sanomi. Thank you.
Good evening, everyone. Can you hear me?
Yes.
Okay, so let me just share my screen. If I can share my slides here. Are we all able to see my slides?
Not yet.
Okay, hang on. That's okay. Can you see them now?
No.
No, we can't.
Still can't see them. Wow,
No.
I don't know what's going on.
All right, you just freestyle.
Okay, so maybe I should just speak and
Yes.
just as
Just
Dr.
stop sharing
Sanomi
then,
has been
and then
doing. Let me stop sharing.
yeah, just stop sharing and then just freestyle.
Okay,
Yeah.
let's see. I think maybe okay. So good evening, everyone. My name is John Lakere Sangbedo. Well, my video is gone. Good evening, everyone. Okay, you can hear me. Okay, fine. My name is John Lakere Sangbedo, and I'm the project manager for GTFIN's Health Foundation. We're delighted to have you on for this knowledge sharing session this evening, and we're glad that you stayed up until this point. But before we close for the evening, and then Dr. Sanomi continues with his session, I'd like to make a few remarks and then give a vote of thanks on behalf of the board of trustees of the foundation. So first of all, I'd like to talk about GTFIN's Health Foundation. So GTFIN's Health Foundation is a health-focused nonprofit set up in 2018 to conduct humanitarian interventions in the health sector. So our interventions take three forms: manpower development, public awareness, and philanthropy. As touching manpower development, what that means is we've been investing in the human capital available in the health sector by conducting trainings and medical seminars for healthcare professionals and lay people as well. We have successfully helped several healthcare professionals upskill and improve their on-the-job performances in many areas. Regarding public awareness, we have consistently drawn attention to several public health issues and continue to use our activities and platform to raise public awareness and empower people with critical information. And finally, our philanthropic initiatives are aimed at helping the millions of impoverished people in our country, Nigeria, with little to no access to quality healthcare. We donate medical supplies, medication, as well as conduct free medical testing whenever possible. So, well, the slides are not up. But Nigeria is a country of well over 150 million people, 70% of which live below the poverty line. We have a severely overburdened health sector, and everything we can do, no matter how little, contributes and goes a long way to making things that much easier for the vast majority. Everything we do now is made possible by the kind donations of a few well-meaning individuals and corporate organizations who support us both financially and in other ways by donating valuable resources that help us put up interventions of varying kinds. It's in the spirit of this that we ask you to consider making a donation to the foundation. You can make a direct bank deposit to our Stanbic Bank account, GTFIN's Health Foundation, account number 0028901410. It's a pity that our slides are not up. I would have, okay. But I've typed the account details in the chat. So for those of us that are able to access the chats, we can see the account details in the comments there. So as I said, you can make a direct bank deposit to our Stanbic Bank account, GTFIN's Health Foundation, account number 0028901410. Or you can visit our page on the Givingway charity platform on givingway.com. That is Givingway, one word. I'll spell it GIVINGWAY.com. search Gintervenes, and then you'll be taken to our landing page where you'll be able to make a donation in your local currency, wherever you are in the world. So sadly, we will not be able to share the slides used by our speakers this evening due to intellectual property issues, but you're more than welcome to watch back today's session on our YouTube channel. So all you have to do is go to YouTube and then search Gintervenes, and then you should be able to access this meeting, because this meeting is being recorded, and hopefully we'll be able to upload the recording by later tonight or tomorrow at the outside. So finally, on behalf of the Gintervenes Board of Trustees and all the staff, I would like to say a very big thank you to our speakers of today for their excellent presentations and for giving us the benefit of their experience and expertise. I would like to thank our sponsors and perennial collaborators in Victory Drugs Pharmacy, plot 57A, 11 Road, opposite 111 Road, Festac Town, Lagos, for those of us in Nigeria, and Encapsulate Healthcare Solutions, who kindly let us use the Zoom platform for these meetings. Finally, I'd like to thank you all for taking the time to join us here, and trust that you found it as informative as I have. And I ask you to join us for more meetings like this in the future. Thank you, everyone. Good night and stay safe.
Okay, thank you very much for that.
Any more questions, or is it okay to start driving?
No, you can't run away yet. We've got more questions.
All right,
for you. That was perfect timing because John just finished.
All right.
So let me just, there was a question here. I had it now. Just give me 1 second. Yes, is hypertension more dangerous in Afro-Caribbeans?
Not necessarily. Blood pressure is blood pressure. The height of blood pressure in any race, if it's very high, will create the same sort of issues. But I think one of the things that we probably don't do much of is taking, preventative measures, making sure we check our blood pressure regularly, having access to those sort of services are taken for granted here in the UK, for instance. If you need to see your GP, you phone, you go, you don't need to think about money. You can see them 10 times or however long. Or however many times, but back in our society where there is no ready access to, good medical care, or people haven't got the money, they may not consider something like high blood pressure, which doesn't give them any symptom, as a problem. And this is why sometimes we see people presenting when they've already had the, end organ damage, or presenting with complications. But on his own, just being African or Afro-Caribbean doesn't mean your own blood pressure is more dangerous than someone, our Western counterparts. It's just the fact that we haven't got ready access to making sure, and the knowledge as well, so you need to have that knowledge to believe, that you need to check your blood pressure and take it seriously, and not just push it to one side and carry on with your daily pursuits because you have no symptoms. So I think that's
so the culture of having annual checks is not embedded in.
And they don't, and the resources are not there as well. And before you go and see anyone, you have to think of the money you want to, or you need to pay.
Yes.
And if people think of that money, they think of having 3 square meals first before they think of a condition that doesn't give them any symptoms, whilst it's gradually causing problems. So they may end up presenting when they've already got developed kidney problems, or even heart failure, or heart is already enlarged because they haven't taken that seriously at the outset.
And speaking of meals and diet, there's a question about carbohydrate. Is our inherently high carbohydrate diet, as in the Afro-Caribbean population, is our inherently high carbohydrate diet the root of most of our problems?
I wouldn't necessarily say the root of most of our problems, but it is definitely something that is not desirable, because you talk about diabetes, you talk about our Afro-Caribbean race or African race, we have high levels of that. Obesity is then the obesity is the kind of root of several other problems. So you heard me talk just now about, being obese as a risk factor. So that can be a risk factor for a number of other things, including diabetes. So I think diet has a strong part to play, but I wouldn't just say diet alone is the root of most of our problems. There are other behaviors. So even if you, watch your diet and you do not take the steps I've mentioned just now to make sure that you have regular checks, just watching your diet on its own may not necessarily lead to the outcomes that we desire. So diet is an important factor, but it's just one of the several factors.
Okay, thank you very much. Do we have any more questions for Dr. Sanomi regarding high blood pressure, hypertension? No? Okay, so now if you have any questions for any of the panel, you can just raise your hand and then we can put it to them. All our speakers are still here. So if you have any questions from the previous presentation or, for hypertension, just raise your hand and then we put your question forward before they go. No questions? Okay. Looks like we've answered all the questions and everybody seems to be happy. On that note, we'll say a very big thank you to everyone for attending. Oh, somebody's raising their hand. Okay. Mr. Salako. Just unmute yourself for me. We can't hear you. You're on mute. Please unmute yourself. You should be able to do that. I've enabled it. There you go.
Yeah, can you hear me now?
Yes, we can.
Yes, the question is going to go to Dr. Tsunami.
Mhm.
Okay, Dr. Sanomi. Yeah.
Tsunami?
Yeah.
We have some reports that most of the problems that people have in the night leading to heart attack is probably because of catecholamines in the bloodstream. Do catecholamines have any effect on blood vessels that will result in myocardial infarction?
Yeah, a good question. I wouldn't necessarily say most of the problems. There are other medical people on the call. They can correct me if I'm wrong, but the catecholamines do play a part. If you have high levels, obviously they will have an impact on your blood pressure. But whether that is the reason for most of the heart attacks, as you put it, I wouldn't, reach that conclusion. They're important in blood pressure. These are things that, if you have high levels, they may constrict your blood vessels, for instance, raise your blood pressure and create other problems and, give you other symptoms. But when you say most of the heart attacks are linked to that, I wouldn't just reach that conclusion.
Anyone else want to add to that?
Yes, if I may, and thank you for that question, Dr. Salako. Yes, a high sympathetic drive, or more specifically, high adrenergic tone may be a contributory factor, but in itself, it's not one of the risk factors. Individuals will therefore have a bunch of risk factors that put them at risk. So for example, they may have coronary artery disease to start with, which would be the underlying reason. And then were they to have chronically stressful conditions or an acutely stressful condition, then that may tip them over into having an MI. So for example, it's not unusual to hear that somebody was doing okay until he had a big blowout domestically, or was accosted in the streets, or some stressful incident, which then caused them to have chest pain. And then, as a result, they had a heart attack. You will find in those people that they have a number of risk factors. As I said, coronary artery disease, maybe diabetes, maybe hypertension, maybe peripheral vascular disease, maybe hyperlipidemia, maybe a family history or a smoking history. So some or all or a proportion of those risk factors will be there in the background, and then that stressful event will be the last straw.
Thank you very much, Papa.
Yeah.
Thank you for that. Anyone else want to add to that? Okay. Any more questions for the panel before we call it a day? Can't see any in the chat. We've just had good comments in the chat. Helen is saying thank you to all the presenters and to the team. And thank you for taking out the time to do this. We thank you. Okay, so thank you to everyone who joined us this afternoon. Thank you for staying on. I've posted the YouTube link in the chat. Feel free to share with family and friends and rewatch. And that is it for today. Thank you very much. So the participants are released apart from the team. Okay.